Welcome everyone to another edition of UCSF Neurosurgery Community Grand Rounds. My name is Manish Aghi from UCSF Neurosurgery, joined by Mariza Daras from Neuro-Oncology and Steve Braunstein from UCSF Radiation Oncology. We're going to be your three panelists today for a very exciting interactive discussion of multidisciplinary care of patients with brain metastases in the era of precision medicine. We want to encourage this session to be interactive, and so we would encourage the audience to use the chat function to post questions and comments throughout the talks. This is going to be a case-based discussion in which the panelists will give their thoughts as to the UCSF strategies for these cases. And we will pause in between cases to go to the chat and take questions from the audience. So feel free to post those questions throughout. And without further delay, I'm going to turn it over to my colleague Mariza to begin today's presentation.
Thanks, Manish. I'm just going to share my screen. Just to begin, I think it's important to highlight the changes in recent years with advances in neuroimaging, radiation techniques, systemic therapies, and supportive care. All of these advances have really impacted and really transformed approaches to patients with CNS metastases. And they've not only improved survival, but they've also mitigated complications. At the same time, they've also increased the complexity of decision-making, particularly for patients that have more complex neuro-oncologic needs. And so today we'll go through a couple of cases, but our team here includes medical oncology, neuro-oncology, radiation oncology, neurosurgery, and palliative care. And all of these key players have really they're part of the ongoing conversation when taking care of these patients, essentially. So I'll start off with two cases first. The first one is, let me get rid of this. The first one is of a 41-year-old man who presented with a generalized seizure and then was found to have a right homonymous hemianopsia. He had an MRI of the brain that showed more than 10 lesions, and you could see some of these on the MRI here. And then he had a CAT scan of the chest, abdomen, and pelvis, and he had multiple soft tissue nodules that involved the lungs, peritoneum, among other organs. So he went on to have a biopsy of the left chest wall mass, and pathology came back consistent with malignant melanoma, which was BRAF wild type. So I'd like to just start off by polling the audience in terms of what would be considered kind of standard practice for these patients. What would they consider standard practice? And I'll just give a few minutes to let them answer. Yeah, so the vast majority of people, it seems like, kind of were split between resection and whole brain radiation, or whole brain radiation followed by systemic therapy. And these were definitely options that we discussed with the patient. So he went on to have a gross total resection of a dominant left occipital metastasis. And initially, the recommendation was for whole brain radiation, but he actually had a high burden of disease systemically. And the medical oncologist started him pretty quickly on IPI and Nivo. And soon after, though, within a couple of weeks, even prior to being able to start radiation, he presented again with headaches, had multiple growing metastases, and he actually had a resection of 2 large metastases. And interestingly, the vast majority of what was found in the histology was necrosis, was actually inflammatory. And so he actually stayed on an ipi-nivo, did not end up getting radiation, and pretty quickly, within a few months, had a pretty significant CNS response. And so these are his most recent scans, and you can actually see he has had a pretty drastic response just with IPI and Nivo, and he remains on Nivo monotherapy, and he's had stable CNS disease and also stable systemic disease. Clinically is doing really well. So that he was a patient that we actually deferred the whole brain radiation on ultimately. So we'll present one more case, very similar, but a different primary. So this is a 68-year-old woman who presented with a focal motor seizure. Again, an MRI showed multiple brain metastases, and she had this dominant left postcentral gyrus lesion that had precipitated the seizure. And again, systemic imaging showed she had a large right upper lobe mass. She had multifocal bone disease and also a large sacral lesion. So she had a biopsy of the sacral lesion. And I'd just like to poll the audience for this particular patient whose pathology came back as non-small cell lung cancer that harbored an exon 19 deletion. So for this patient, just want to poll the audience and see what would they consider standard practice. Great. So it seems like the majority of the audience recommended resection of the dominant metastasis followed by SRS. This was something we absolutely discussed with the patient. She actually opted to defer surgery. She was reluctant to do so. And because she had an EGFR mutation, we actually quickly started her on osimertinib, monitored her very closely, and left kind of the option for radiation and surgery, depending on what the subsequent MRI showed. This was the MRI 6 weeks on treatment, so she had a pretty drastic response, even with this larger metastasis here. And then she remains a year later, a little over a year later, remains on OC with stable CNS and stable systemic disease, and these are her most recent scans. So I think what is really interesting is, and it's something that's coming more and more in conversation, is what's the role of systemic treatment in the management of patients with brain metastases, and can we actually defer local regional treatment? Are the outcomes the same? And outcomes have definitely improved with immunotherapy and targeted therapies for particular populations of patients. And there are, we have data on systemic treatment with radiation that have shown improved outcome, improved survival, and there might be benefit there in combining systemic treatment and SRS. The data on systemic treatment alone is still really emerging, and CNS penetrant TKIs such as osimertinib are showing near comparable outcomes, especially with asymptomatic patients. But we know that there's with radiation, there's a reduced risk of intracranial progression, especially with upfront radiation. And Checkmate 204 actually showed that deferring local regional therapy for asymptomatic patients was feasible, with intracranial response rates of 53% and a overall survival at 36 months of 72%. And so, the question I think often comes up is, when we have good CNS penetrant options, can we defer radiation? And is that sufficient in terms of controlling CNS disease? And so there are a number of ongoing trials investigating the role of different systemic combinations and surgery for these patients. But I think it's really important to keep in mind that for a large proportion of patients, we actually don't have effective CNS penetrant drugs. And so our radiation and surgery is really important. So I'd just like to have Manish and Steve kind of comment a little bit on what might be the optimal timing of radiation and surgery for these patients. And Manish, maybe you can start commenting on that.
Yeah, so I think all of the time points you've put up there are potential time points for surgical intervention. I think the cases cases 1 and 2 that were just presented, there were other sources of tissue, but in the modern era, in the setting of multiple metastasis and a lack of a systemically accessible tissue source, craniotomy for a metastasis in many non-eloquent locations is is a very viable approach to get tissue and establish a diagnosis. And then if that metastasis happens to be the dominant metastasis, as was the case in the 2 examples you presented, there can be a role also for symptomatic relief at the time of initial diagnosis. And then similarly, if there's residual disease or an incomplete response after an initial treatment, those are times when we've intervened in the past. Usually more though in the setting of the third scenario that you've presented, which is progression as opposed to stable residual disease. So I think all of these are scenarios where surgery can be, and the sort of folklore that surgery after radiation or SRS is somehow more problematic or more prone to complications really isn't true. I think we're going to be going over some cases later where even surgery for radiation necrosis has a role. So.
Yeah, and I would add from a radiation perspective, it's also an open question and really needs to be thought about on a case-by-case, patient-by-patient basis, and that's what we do in practice, of course. It's really amazing what we've seen in terms of the responses to these newer CNS penetrant therapies, TKIs, the BRAF/MEK inhibitors in melanoma, and immunotherapy. But it's also important to note that these studies are still maturing, and while there's really profound initial rates of response, the late durable control is something that remains an open question. The one thing that we do know is the toxicities associated with radiation, which have been well established, especially with whole brain radiation. And so we're thinking about these patients that are now living much longer now than they were before. They're certainly going to be potentially subject to the sequelae of whole brain radiotherapy. And even radiosurgery is not without potential sequelae. And we'll certainly talk about that today. So it's really thinking about it on a case-by-case basis. I think as the data matures and we're reassured that we're getting good, durable control with some of these therapies in select individuals, we may be in a position to selectively defer radiation along the pathway. But from our perspective, I think it's critical to consider, what are the salvage options should someone progress? When does a lesion become so large that maybe they're not going to be readily salvaged by radiosurgery, or the lesions may become so numerous that radiosurgery is also not applicable? So we're thinking about the patients in the current setting and where the disease may go if these agents aren't as effective as we hope.
Steve, talking about toxicity, I think sometimes the other question that comes up is when combining SRS with systemic treatment, is there a higher risk of hemorrhage? Is there, particularly with immunotherapies, is there a higher risk of inflammation? And can you comment a little bit on that?
Absolutely. I mean, this is certainly a concern as these therapies have rolled into the clinic over the past several years, and there have been a few provocative case reports of potential augmented toxicity when used in combination. I think we're at a point again where the data has matured and they're more ubiquitous in clinic, that thoughtful, cautious use of these agents in combination with radiation is feasible and doesn't appear to be routinely associated with great toxicity. That being the case, in practice, many groups, including our own, will often hold these agents if they're given on a daily or weekly basis, whatever the cadence is, but at the time of radiosurgery, 72 hours before, 72 hours afterwards, to be conservative and safe. But if you do a scoping review of the literature, you will see occasional case reports of more augmented toxicity, for example, with combination of checkpoint inhibitor therapy and radiosurgery, meaning that maybe there's a higher risk of adverse radiation effect, radiation necrosis. But on the other hand, there also may be some augmented synergistic control of disease. And so it's really a balance between the two. But I think you make a good point about being thoughtful in the sense that for those patients, for example, we're giving checkpoint inhibitor therapy and they're at risk for having adverse radiation effects or radiation necrosis. Those agents may be profoundly effective in terms of the disease burden, and we want to keep them working optimally. So we're really hesitant to put patients on steroids, for example. We want to avoid toxicities where we would need to potentially compromise the efficacy of the treatment. So I think being conservative, holding these agents for just a few days on each end is probably most apt.
Thank you. Manish, I just want to check in if there are any questions in the chat before we move on to the next cases.
No, I think we can move on, but again, for the audience, we will be circling back to the chat throughout, so feel free to post questions, but for now we can move on.
Great. So along those kind of themes that we've just talked about, we'll talk about another patient here. This is a 46-year-old woman who had a history of colorectal cancer diagnosed back in 2018. It was treated surgically. And then several years later, she presented with headaches and nausea, vomiting, and had an MRI that showed, again, multiple metastases, and systemic staging showed lung cancer, lung and adrenal metastases. Pathology, I'll just eventually get to that, but pathology, again, for this patient confirmed colorectal cancer. But I just want to poll the audience one more time for this particular case. What would they do? How would they treat this patient? Great. So this is kind of a little bit mixed, but the majority have selected SRS and resection, SRS, and systemic treatment. So that's what we ended up recommending for this patient. She had a resection of a dominant right frontal metastasis. Again, pathology was consistent with KRAS mutant colorectal cancer. She had gamma knife to the surgical site and two largest metastases, and then to the several other smaller metastases. And so just, I'll move on actually, just again, similar discussion, but I think it's important to highlight in circumstances of multiple brain metastases to talk a little bit more again about the role of surgery and local radiation versus whole brain radiation, and also resection of a metastasis in the circumstance of multifocal disease. And so Manish, I think it's important to think or for us to talk a little bit about what goes into consideration when a patient presents with multiple metastases as to whether surgical resection of a dominant metastasis is appropriate. What are the risks that are discussed with the patient, and when is this most appropriate?
Yeah, it's a great question. So we start out by, the question of symptomatology that could be potentially attributable to the dominant metastasis and whether surgery may be most capable of providing symptomatic relief. And then cases like that, we certainly loop in our radiation oncology colleagues and medical oncology colleagues, since there's often broader systemic disease in those patients, and get a sense of the radiation plan with or without surgery, and whether surgery will have some benefit on that plan, such as potentially, I'd be curious about Steve's opinion, but the case you just presented, the dominant lesion after surgery, I think had 3 fractions. And sometimes you can have a case where the resection reduces the number of fractions for a dominant lesion. Obviously, the smaller non-dominant lesions may be single fraction treated, but I've certainly done cases with Steve where it feels like surgery takes it from a 5 fraction target to a 3 fraction target. And that would seemingly, again, I'll defer to Steve, but seemingly provide some better control. But of course, you have to integrate that with the level of control you're getting with all the other disease, because any single site of failure sort of undermines the whole treatment plan. And then also the question of timing. So surgery can delay the radiation oncology intervention. And the last thing you want to do is be stuck in a whack-a-mole scenario where you operate on the dominant lesion and the non-dominant lesions grow in the interval. And so I think we will certainly, we've certainly had patients go to radiation as soon as 2 weeks after surgery. We've had I think Steve may recall a few cases where we've proceeded with the treatment of the non-dominant ones to keep them at bay, and then keep waiting for the surgical cavity to get smaller before adding the multiple fractions for that one. So to sort of address the issue of what happens with the delay when you do surgical intervention. But those are some of the considerations. It's definitely a multidisciplinary discussion because, as people know, it's somewhat contrary to conventionality to operate in the setting of multifocal disease.
Yeah, and I can add, it's interesting that so much the definition of multiple brain metastases continues to evolve. We have high quality evidence dating back now decades supporting the use for radiosurgery alone for up to 3, 4, 5 metastases. We now have some ongoing trials looking at up to 15 or so metastases, comparing radiosurgery versus whole brain radiotherapy or modified whole brain radiotherapy. But in practice, we have abundant retrospective evidence supporting the safety and efficacy of using radiosurgery to treat multiple brain metastases, irrespective of a dominant lesion that may be appropriate for surgical resection. So where possible, I think in practice, many centers are favoring radiosurgery for multiple metastases, again, that are generally not particularly symptomatic, because it's important to appreciate, and Manish mentioned this, that the role of radiosurgery is excellent in terms of local control, but you're not going to see dramatic reduction in the mass effect or edema following radiosurgery. In fact, it can go the other way, and you can have more profound reactions. So someone who's symptomatic, I think, certainly is a great candidate for resection of a dominant lesion or lesions. But radiosurgery can be used to treat multiple brain metastases well. But there's still a role for whole brain radiotherapy in select instances, something that's more comprehensive if there really are an abundance of lesions, 10, 20 plus lesions. There's certainly a burden of micrometastatic disease that's not appreciated even on high resolution MRIs. And so those patients may be better served with whole brain radiotherapy or the modified hippocampal avoidance whole brain radiotherapy that can allow for some improved cognitive preservation. But when it comes to treating in the postoperative setting, or in general, I should say, what we're trying to do with radiosurgery, of course, is provide excellent local control, but avoid toxicity. And we're trying to use very high ablative doses. And despite the tremendous advances in technological delivery of radiation through radiosurgery platforms that span from GABA knife, CyberKnife, linear accelerator-based treatments, there's still always some dose that would be deposited to normal healthy brain parenchyma in the region of the lesion target. That's unavoidable with any type of delivery. And you can imagine as these lesions that we're targeting are larger inside, there's going to be a larger interface with normal healthy brain tissue. And that means greater dose deposition into healthy, uninvolved brain tissue. And that increases the risk of potential complication and radiation injury. So as Manish was saying, in the postoperative setting, really we're trying to treat just the surgical cavity alone with minimal inclusion of healthy brain parenchyma. So we often will undertake a process where following surgery, we'll image the patient and look for a shrinkage of the operative cavity, which does happen over time, over a few weeks, to try to maximize the geometry to treat the smallest cavity as possible. But we still will fractionate often. The role of fractionation is more so to be able to augment the therapeutic ratio so that we are causing less harmful dose to regional brain tissue, giving more time for that brain tissue to repair some of the damage per fraction, but not compromising the efficacy of the radiation. So the role of fractionation, while I think evolving in radiosurgery, traditionally is used really to minimize potential radiation injury. And so in that vein, I should mention that there are some studies looking at the role of doing preoperative radiosurgery to lower doses, which can also potentially mitigate complications associated with high dose to normal brain parenchyma.
Great, thank you. Manish, I'm just going to pause there before I move on for this case. Are there any questions in the chat or Q&A?
Yeah, there are. So I'm going to start with, I think this question for both of you, but maybe Mariza, you a little more. But so we've touched on the role for surgery and symptom relief or addressing symptoms. And then Steve mentioned that, you know, SRS may, in some cases, temporarily worsen symptoms due to the reaction to radiation. But the question is, What about systemic treatment, in particular with checkpoint inhibitors? We saw some nice examples of radiographic responses. Is that systemic treatment with CPIs associated with symptomatic relief?
I think the challenge with checkpoint inhibitors is that sometimes the response is delayed. And as we saw in the first patient, there can be an initial inflammatory response before you see regression of the metastasis. And in these patients, we definitely do not want to use steroids because it will impact the efficacy of the immunotherapies. And so those are often patients where surgery can actually be very helpful, particularly if there is if the metastasis is accessible. In circumstances where it's not, sometimes the role of Avastin has come up, whether we can use Avastin as a steroid avoiding or steroid sparing agent while allowing for the immunotherapy to work. And I think that is often involves kind of a conversation with medical oncology as to whether we can do that, whether it's safe, especially if there's evidence of hemorrhage within the metastasis. And it's not something that we really have a lot of data to help drive the decision-making. But so often when surgery is feasible, that's typically what we'll recommend for symptomatic relief.
That makes sense. And then the other question for you, Steve, from the chat is, you had touched on this briefly, but perhaps if you could elaborate a little bit, the role, the pros and cons, or the cases you would consider doing pre-op SRS for.
Yeah, absolutely. I think this is a very creative area in so much as it can potentially mitigate some of the late complications of doing high-dose radiosurgery to larger targets. And I also didn't mention that one of the challenges in the postoperative setting is really understanding the target delineation. That can be very, very challenging. These patients after instrumentation may be at higher risk of local dissemination that can lead to leptomeningeal disease as a severe sequelae of the intervention. And so it can be difficult to target in the intact setting prior to resection. The target is more well defined, and we don't have to struggle as much understanding how much of the resection cavity and dura and path to tumor needs to be included. But the challenge with preoperative radiotherapy is that these patients that are coming in with larger lesions are coming in symptomatic. And so there is a workflow involved, even when we expedite this workflow, that may require, in some cases, a day or two, sometimes 3, to be able to effectively coordinate the care and perform the radiosurgery process. I think many groups are trying to be more processive and expedite this process, but for someone who has a significant edema, midline shift, they really need to get to surgery quickly. Often they're coming through the emergency room, and it may not be feasible to get them in for a radiosurgery. But this may be a challenge that can be overcome. So the patients who may be most appropriate are the patients who have a larger lesion that has indication for resection. Maybe they have some symptoms, or maybe there's some diagnostic utility in having the resection, but are stable enough that they could wait maybe 1 to 3 days or so to be able to undergo preoperative radiosurgery. And I should note that there are still studies that are being run to compare preoperative and postoperative. So we don't, fully, I would say, appreciate, what the long-term outcomes are of the differential approach.
Great. Those are all the questions in the chat, if you want to.
Perfect. So let's move on, keep going in this particular case. So she actually declined systemic treatment. She opted to go with alternative treatments for some time. And then within a 5-6 month period, she presented with a seizure, hemiparesis, and aphasia. And the MRI showed, again, a dominant left parietal and then high left frontal metastasis and multiple new metastases. So I'd just like to poll the audience. What would you recommend in the setting of recurrence following resection and SRS for this patient? So we'll just take a short minute for this. So the vast majority of the responses are resection, followed by repeat SRS, resection whole brain radiation, and resection brachytherapy. So kind of split between those three. And I think those are all really reasonable options. So for this particular patient, we actually recommended resection of the left frontal and parietal metastases. She had brachytherapy seeds placed, and then she had gamma knife to the additional metastases that were present, and she started FOLFIRI and bevacizumab. And she continues to remain stable, both systemically and in terms of her CNS disease, and this is her most recent scan. So I just want to open the discussion again in terms of local regional therapies in the setting of recurrence following SRS. We often will try to change the systemic treatment if there's a better CNS penetrant drug, but particularly for symptomatic patients, we will rely on surgery or radiation for these patients. And I just want to open it up again to Steve and Manish. In terms of, Manish, for you, when you're thinking about re-resection in patients, again, what's your kind of thinking process in terms of when is it appropriate?
Certainly in the setting of recurrence or progression following SRS, one of the delineating considerations is whether it was a tumor that was operated on prior to the first SRS or if it was just SRS alone. I think either way, re-resection is often a strong consideration in that scenario. Tumor size is a consideration, or the size of the recurrence. If the recurrent and the timing of the original SRS, if it's a delayed and sort of a recurrence with manageable size, then repeat SRS is very common, and particularly if it's in the setting of a broad sort of number of intracranial foci previously treated. But if there's not a lot of cranial disease, if it's a large recurrence that came on somewhat rapidly in close proximity to the original SRS, then those would be scenarios where we would think about re-resection. And much as you mentioned, changing things up systemically when this happens, I think it's important. We at least in our institution, we consider changing things up when it comes to the local therapies, and that's where brachytherapy comes into play. The repeat SRS biologically is exerting the same exact mechanism as the first SRS. And obviously we can overlay treatment plans and cover areas differently than they were the first time. But brachytherapy provides, and Steve can get into the details of the dosimetry, but provides a different formula of control that can be useful in the setting of recurrence following SRS.
Yeah, when I look at this context for this question, often in practice, we're thinking about local regional therapies in the question of question mark following SRS. And so we're following these patients through interval radiographic imaging, and we see changes in the area of a lesion that was treated. And it's very hard to discriminate true recurrence often from pseudo-progression and treatment effect. And that's a challenge for us. It's a challenge for good patient care, because generally earlier interventions, whether it be to treat possible adverse radiation effect, radiation necrosis, or tumor progression, are important. So this can essentially delay appropriate management of patients. So for many reasons, if a patient is a good operative candidate, I think we slightly favor using surgical approaches to be able to identify with a gold standard pathologic diagnosis of what is happening following radiosurgery. The rates of altered imaging, what I would call adverse radiation effect, can be as high as 50% in some cases following radiosurgery. And so this is a real challenge for us. That being said, when we are faced with this challenge, one thing that we do know, again, I focus on the toxicity, is that for patients, the highest risks associated with having radiation necrosis are more radiation And so for patients who've received prior radiosurgery, to do additional radiation on top of that, we are going to increase potentially the risk of radiation injury down the road. Now, it may be indicated to achieve good local control of a recurrent lesion, but we really want to do everything possible to try to obtain good local control and minimize the late toxicity. For smaller lesions that appear to be congruent with recurrence, we might offer repeat radiosurgery, and especially if the patient is otherwise a good operative candidate, or these lesions are in eloquent areas, or perhaps not just thinking about the cranial burden of disease, but the extracranial burden of disease in the patient's on systemic therapy, and we're trying not to disrupt that during the process, perioperatively for resection and having to hold systemic therapy. So radiosurgery or repeat radiosurgery may be indicated. As Manish said, increasingly, we and others, as it's becoming more popularized, are using brachytherapy as part of the intervention. So patients will go for a re-resection, so we're able to get pathology confirmation of recurrence, and then use these radioactive brachytherapy seeds to place within the resection cavity to deliver very high dose radiation in a way, as Manish intimated, has great geometric precision. And so we're really delivering that radiation just to the walls of the cavity where the lesion was resected, and in some ways may have a slight dosimetric advantage as compared to radiosurgery, because the radiation is being delivered internally rather from an external process. And so when that's performed in such a way, the dose gradients are the steepest gradients possible to really just treat that region, the immediate region of the surgical resection cavity, and give very little dose to the rest of the brain. So I think it has the advantages where appropriate to offer excellent local control with a very, very high dose, higher in many instances what we can achieve with radiosurgery, with a more limited gradient into normal healthy brain tissue, thus helping to mitigate potential toxicity. So I think increasingly so, we are using brachytherapy.
With that, Steve, I'll let you talk a little bit more about brachytherapy.
So this is a very nice picture just to visualize it, as this is something that may be a little less familiar to many individuals, but essentially brachytherapy employs a radioactive source. So it's a source-based radiation. There are different isotopes that are used. We're currently using cesium-131, which has a relatively short half-life. So these can be inserted into different parts of the body. We're using it here as part of craniotomies and tumor resection. And there's different methods. They can be delivered as free seeds, and you can see they're very small. They look like almost little iron filings shown on the right. They can be stranded. They can be inserted into wafers and placed there, and that can facilitate the ease of placement for folks who maybe have less familiarity with brachytherapy seed placement. And so these are encased in a non-reactive material, so a titanium case, and they're ordered prior to planned resection of a tumor. And at the time of resection, after path confirmation, we'll place these in a manner to space them out appropriately to cover essentially the entire cavity. Manish can maybe speak a little bit more about his approach here, but these have a very, very high activity and depositing a very high dose of generally the prescription is 80 gray to half a cm from the cavity, and that can really be very ablative in terms of any residual microscopic disease. And it's not new, I should say. I mean, this has been done for decades. The isotopes have changed. You can see the cesium-131 has a half-life of about 10 days, which means that after just a few weeks, these are no longer radioactive. So there's no special safety precautions. Usually in practice for patients receiving CNS brachytherapy in the metastatic setting, we're taking measurements and readings in the operating room. We're taking measurements thereafter, and patients, they may need to wear some prophylactic lead shielding, which is placed in a cap for a few days. But after just just a few days, they can generally go home and have no precautions in terms of proximity to family members. So the studies really support safety and efficacy. And here's some of the data. This is some data from Cornell. Some of the initial experiences used here. You can see excellent rates of local control. And this is these are in patients who have had previously treated brain metastases, so just the setting that we're talking about. So really great local control here. And then here's our experience that Will Chen had published. And you can see similarly, the rates of local control at a year are upwards of 80%. And very limited cases of radiation necrosis or injury in this initial cohort. So I think there's a clear role, and others have subsequently published their experiences, and you're seeing consistency in excellent outcomes with regard to local control and very modest toxicity overall. And here's just an example of a patient that I think speaks to two considerations. One, this patient initially received radiosurgery in 2014, and you can see that over time the lesion resolved radiographically, but then there was a signal abnormality that came back 5 years later. So these are patients that are living a lot longer with brain metastases, and there's the possibility of now of potential late recurrences or late radiation injury in these patients. So this patient ultimately underwent resection that had proven recurrent metastatic breast cancer, and we placed seeds at that time.
Great, thanks, Steve. So before I move on to the next or the last two cases, just wanted to check, Manish, if there are any questions in the chat that.
Yeah, we have two. So Steve, do you ever consider placing brachytherapy at the time of an initial resection, or do you use it exclusively in recurrent cases?
Great question. And so we do. I think the challenge is similar to what we have with preoperative radiation, and that there's a bit more planning that needs to be considered because of the nature of the production of the seeds. We're now at a place where we can get these seeds or these tiles or wafers very quickly within just a few days. But for a patient that's coming in with an emergent indication for craniotomy and resection, we're not in a state where we have the seeds immediately available, so that requires some preoperative planning. But I think there's certainly a role for using brachytherapy in the upfront setting for metastases.
Great. And then Mariza, what's your opinion on the value of tissue sampling in the setting where the primary is known, but you're talking about tissue sampling purely to guide further systemic therapy, given that the mutations in brain metastases may be different than those in the extracranial sites?
So in general, while it's particularly in a heavily treated patient, I think it can be helpful to look for resistance mutations if there are any additional systemic therapeutic options. But in practice, I think it's pretty rare that we will discover something in a CNS metastasis that's drastically different than the systemic histology that really alters our course for systemic treatment. And so unless a patient is symptomatic and it really warrants surgery in terms of managing symptoms, it's rarely something that we'll recommend surgery for tissue only in order to assess for systemic options, particularly if we have pre-existing tissue. So I hope that answers the question.
It does. I think we can move on.
Great. So let's move to the last two cases. And this touches upon a little bit of what we've talked about already. So this is a 69-year-old man who had a resection of a cutaneous melanoma back in 2018, and then years later presented with dizziness, nausea, vomiting, and a headache. He had two metastases, a large left cerebellar and a smaller right temporal met. He had a resection of the cerebellar met and pathology confirmed BRAF wild type melanoma. And he was treated with SRS to the surgical cavity and then also to the right temporal metastasis. He went on to have IPI and Nivo, stayed on Nivo maintenance. And then about a year later, he had an MRI of the brain that showed an increased right temporal previously treated metastasis with increased enhancement in edema. And so the concern there was for recurrence. As Steve mentioned, though, in a previously treated lesion, sometimes there's a question as to what is actually there, but this was a significant change. There was significant progressive growth of that lesion. So ultimately, he had a resection, and he had brachytherapy for the right growing temporal metastasis that was confirmed to be active tumor. He actually had a seizure in the setting of tapering his anti-seizure medications postoperatively, but recovered. And then about a year later, he had this MRI, which showed increased enhancement and edema, a slightly different enhancement pattern than previously seen. And this was at the site where he had SRS and then also had the brachytherapy seeds placed. So the question was, are these radiation-related changes, or is there a component of progression of disease? And I'd just like to poll the audience for a case 4 poll question. Yeah, so the vast majority of people said a trial of dexamethasone, and that was definitely something that we had thought about. But for this particular patient, what we ended up recommending was actually a re-resection, and we'll kind of explain our thinking. And his path is actually confirmed that this was all inflammatory. There was no viable tumor, and he recovered really well postoperatively. So for this particular patient, he was somebody that had systemic progression, and his medical oncologist was trying to get him on a clinical trial. And steroids would have excluded him, Avastin would have excluded him, and progressive CNS disease would have been an exclusion as well. And so surgery, and this was a conversation that Manish and I had. We shared the care for this patient, and together with his medical oncologist, ultimately recommended surgery, because that would be the bridge, if this proved to be all inflammatory, to get him on that clinical trial. And he did successfully enroll on the trial and has remained asymptomatic since, and clinically doing really well. And then this is the last case, very similar, but a 67-year-old man presented in 2020 with an elevated PSA. He had a PET scan that showed multiple lesions in the lungs, brain, and bone. He had an MRI of the brain as staging, and he was confirmed to have multiple metastases, left being in the left occipital lobe. He had these 2 other ones as well. So he had a resection of this left occipital met, and his pathology was consistent with prostate cancer. He ultimately went on to have gamma knife to the additional sites and to the resection cavity as well, and then started systemic treatment with docetaxel and carboplatin. And he ultimately experienced progressive headaches about 6 months after radiation, approximately. And this was his July 2020 post SRS MRI. And then this was December 2020, several months later. And he had this ragged enhancement pattern with marked edema around. And the concern there was, could this be progressive disease or radiation necrosis? So Ilana, if you can pull the last question, how would you treat this particular patient? See what answers we have. Yeah, so we did actually start him on dexamethasone. He actually didn't tolerate the steroids very well. He had a lot of insomnia, and ultimately we decided to move forward with a dose of Avastin. He got a single dose, but we had initially planned for 3, but due to severe fatigue related to the medication, he didn't want to proceed with any additional treatments. So with a single dose, he actually had a pretty drastic response, and this was his last MRI. So almost 3 years later, he remains stable in terms of his CNS disease. This is his most recent scan, and he has no evidence of he has some systemic progression of disease, but CNS remains stable. So I think this is the last topic of conversation, something that we've touched upon throughout this presentation, but I think it highlights some of the treatment-related complications that these patients face. Something that often comes up is radiation necrosis. And in the literature, the range is anywhere between 5 to 25%. Sometimes some reports are higher. And I'll let Steve, if you wouldn't mind, talking a little bit about the UCSF experience. I know Dr. Sneed and you all have published on this topic.
Yeah, absolutely. I mean, this is a potential sequelae of treatment with high-dose radiation to the brain. And you can see here just the data. It's generally a function of both the dose and the function of the volume of what's being treated. So we tend to be conservative, and our rates of radiation necrosis may be slightly lower than what's been published in literature. It's important to recognize that when we talk about adverse radiation effect, it can be imaging-based and reversible versus, frank symptomatic radiation necrosis. But the biggest risk is patients who've had prior radiation. So reirradiation is most associated with higher rates, I think intuitively, of radiation necrosis. And this can happen at a pretty wide range following radiosurgery, anywhere from the subacute setting, just a few months, to well over a year. But most of the time it's happening within the first year following radiosurgery.
Great, thank you. And in general, in practice, steroids have been really the backbone of treatment, but I think we're all well aware of the limitations of steroids in terms of long-term side effects, and also particularly for patients who are on immunotherapies. And so one approach has been the use of bevacizumab, and there's prospective data is pretty limited. I think a lot of the practice patterns are driven by retrospective data, and there's, I think, only one treatment algorithm that was published recently by the German Society for Radiation Oncology in 2022. And a lot of the prospective data is really based on management of radiation necrosis in the setting of treatment for nasopharyngeal carcinoma, AVMs, or primary brain tumors. So there's not a lot in specific to brain metastases, but nonetheless, it is a drug that's used that we use frequently for the management of radiation necrosis. There are reports of significant and durable responses. Often radiographic responses really correlate with symptomatic benefit. And I think that's really the most important thing, that patients do have a symptomatic response to the bevacizumab. It's not clear what dose to give, and it seems that response is not really dose dependent, and studies have looked at doses anywhere between 1 to 15 mg per kg given every 2 to 6 weeks. The duration of treatment is really not well defined, and often in practice we'll use anywhere between 1 or 9 treatments. Sometimes patients will come off of the drug, they'll have rebound edema, and will have to resume therapy. And the recurrence rate post bevacizumab is really unclear, and literature is anywhere between 10 to 39%. And unfortunately, a randomized trial of steroids versus bevacizumab for radiation necrosis related to brain metastasis was terminated due to slow accrual. And so I think we'll be in a situation where we'll not have really specific data for this patient population, but we'll extrapolate based on other experiences. And lastly, Manish, if you can comment a little bit about the role of resection in the management of radiation necrosis. That's something that frequently comes up and came up in one of the previous cases, at least.
Yeah, I think it definitely has a role. We've been referred patients for surgery who have side effects of steroids or inability to taper, more commonly, contraindications to bevacizumab. Sometimes fall risk and its associated bleeding can be a contraindication to bevacizumab. And then just the severity of the symptomatology, even in the setting of steroids, can lead to surgery. Histologic confirmation actually ties in with a question we do have in the chat, so I'll sort of answer that question here, which is absolutely appropriate. I mean, if obviously if you're going to continue steroid treatment, it would help to know that you're actually using it appropriately and that there is indeed just necrosis. And the question in the chat was whether the pathology is treated as a binary variable, like all necrosis or all tumor, or to what degree it's usually going to be a mixed finding, and how do we manage that? And it's a great question. And particularly as it relates to brachytherapy, because if you're talking about a systemic treatment, you have the luxury of waiting for final path on the entire specimen. And I would defer to you, Mariza, as to how you would handle it if the pathologist says it's, 20% viable tumor. But in the OR, we're relying on the sampling that occurs with a frozen section. But I believe, Steve can comment on this as well, but for brachytherapy, as long as there's viable cells in the pathology specimen in the frozen section, we proceed with brachytherapy. But we certainly have had cases where nothing's viable and then we don't do the brachytherapy.
Yeah, I think the question on some of that depends on timing of treatment. For example, the first patient who was on immunotherapy, had a resection, no prior radiation, and it was 3/4 inflammatory. And in that particular patient, ongoing systemic therapy would be appropriate. But in a patient in whom there is recurrence after prior treatment and there's viable tumor, I think you have to count that as recurrent tumor. And if there's a surgical option, ultimately the surgery will help alleviate both some of the inflammatory nidus that's there. But then ultimately, I think if there's viable tumor, you have to change the systemic treatment if there's one, especially if there's one with good CNS penetration. So just to kind of summarize everything in the last two slides, I think, again, our treatment approach here takes into account a number of different things, including the number of CNS metastases, as you've seen already, the extent of systemic disease, the patient's functional status, targetable options in terms of systemic therapies, and the number of prior systemic therapies. And I think one of the key things that has come up is the treatment of symptomatic versus asymptomatic patients. And in symptomatic patients, really alleviating those symptoms through surgery or medications such as steroids or Avastin is really critical because that can impact patients' function. And so this is somewhat of an algorithm or kind of a skeleton to our thinking process. But there's a lot of gray area, and I think that's important to recognize that for each particular patient, particularly these more complex patients, there are multiple moving parts. There's sometimes limited data. And so this is where a multidisciplinary approach is really important to facilitate care and increase communication between providers. We know it can increase access to care. It can improve outcomes. It can impact patients' quality of life. And it can facilitate coordination of care, both as we've done here within our institution, but also when we're taking care of patients who have local providers as well. So with that, I'd just like to thank everybody. This is the contact for our new patient coordinator. And again, if there are any last questions in the chat, just like to open up to that.
Well, thank you. This has been great discussion. And if there's any questions, we can take a few minutes in the chat. Otherwise, you can always email the address on the screen with questions about specific patients or scenarios. All right, well, I think we can probably wrap things up then.
Thank you.
Thank you.
Thanks, everyone.